Hi class, welcome back to Biomedical Ethics. So very briefly, I'll be going over current genetic testing options, and then we'll be talking about issues of genetic justice and how autonomy and paternalism can conflict. We won't be talking about designer babies today, as we have an entire lecture on that on Wednesday. So I'm looking forward to discussing that in more detail. Okay, so just to set the stage, we are currently in what's been called the genetic era. And the genetic era began in 1953. So it's a relatively new period of time. And this is when we can or have the ability to modify um, the human genome. So in 1953, Crick and Watson discovered that the double helix was the shape of DNA. So we learned the shape of DNA, the chemical compound that encodes instructions for producing and maintaining all human beings and all living beings on the planet. Fast forward to 2003, scientists were then able to chart the length and breadth of the human genome, aka the human genome was sequenced. And today we're able to pinpoint genetic factors that contribute to diseases. And we are also researching ways to change or alter genes to cure such defects in the future. So if you have time, there's a great TED Talk that just goes over the Human Genome Project and how we sequenced the human genome. So just take some time to look over that if you're interested. It's only a 4-minute video, but it is quite fascinating. So today, fast forward, a person's genome can be sequenced in only a few days, and genetic testing includes over 2,000 tests designed to test for various diseases. Now, what are these tests? Well, there are various types of genetic testing that you should be aware of, if not already. There's newborn testing. These tests focus on uncovering genetic diseases for early or identifying genetic diseases for early treatment. Carrier testing. These determines if someone is a carrier for a type of genetic disease. So if two carriers have a child, for example, this greatly increases the chances that that child will also develop that disease or will develop the disease. The parents aren't necessarily are only carriers, so they haven't necessarily developed the said disease. Predictive testing, and this finds out before symptoms are present if someone is likely to develop a genetic condition such as Huntington's, and we'll be discussing Huntington's in more detail. And it's important to note here that these tests only determine probability and not certainty. So that's an important factor. Then there is prenatal testing. Diagnostic testing to confirm or rule out a genetic disorder. Prenatal testing to determine if a fetus has genetic abnormalities that could cause impairments. And then we have connected to IVF, and remember IVF is relatively new, late 1970s. Pre-implantation genetic diagnosis, PGD, to determine if embryos produced through IVF have genetic abnormalities so that they are then not utilized in the further surrogacy, etc. Now, these tests seem like it's pretty cut and dry. You know, they give us more information so that we can treat patients more effectively. However, there are a few problems with genetic tests that should be discussed and recognized before moving on. First, it's important to note, as I stated earlier, genetic tests typically do not give conclusive answers. They only deal in probabilities, so the probabilities of developing a disease. So for example, let's say you found a mutation in the BRCA1 or BRCA2, in BRCA1 or BRCA2. This translates into roughly an 80% chance of developing breast cancer. This means that you have a 20% chance of not developing breast cancer. So most genetic disorders are the result from abnormalities in several genes and or interaction between genes and environmental factors. So you have uh, a probability of developing a condition, and there's a good portion of people who are susceptible to developing a condition that will not develop said condition. In addition, the as most disorders will result in several abnormalities in several genes, well, in abnormalities in several genes, you might have an abnormality in one, but not in the others. And we're still determining for several different diseases what all the abnormalities would be. In addition, environmental factors play a huge role or can play a huge role in whether or not you will develop a disease. And so epigenetic factors should be taken into account as well. So scientists may not know all the mutations responsible, and this could impact the probability. And environmental factors could cause mutations later, which could increase probability of developing a condition. So in short, positive or negative results, they might not guarantee that a disease will or will not develop. We're not dealing with certainty here. We're dealing with a roll of the dice and higher probabilities. Now, let's say the tests are accurate and you are going to develop a particular ailment. Even when they are accurate, they can't foretell the severity of the symptoms. So let's just for argument's sake, both of these women do not have mutations in the cystic fibrosis gene. Well, but let's say they do. Let's say both women have mutations that will cause them to develop cystic fibrosis in the future. One woman could develop mild symptoms while another could develop severe symptoms. So even if tests are certain, the severity of the disease and the particulars associated with that disease may not be similar across the board. So that's important to recognize as well. In addition, there are concerns that genetic testing could break the principle of non-maleficence or do no harm, because just knowing that you're going to develop a disease could place an emotional toll on people. So this is particularly the case when we can identify way more diseases than we can currently cure. So knowing you'll develop a disease may push a patient into depression. The low chance of developing a disease could weigh on somebody. Let's say, let's flip it. Rather than the 80-20, let's say you have a 20% chance of developing a particular ailment. This, even though it's a relatively low chance of developing something, it may weigh or place an emotional toll on a person. And there could be social stigma attached to being a carrier of a disease. I mean, do you put that on your OkCupid account, etc.? What happens when you state, oh, well, I am a carrier for blah, 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 or, I have a 20% chance of developing cystic fibrosis or something like that. So there could be a social stigma attached to being a carrier. Now, what I asked class to do is to imagine that one of their patients has a family history of Huntington's and has children. Do you have a moral duty to be tested? And if the test is positive, do you have a moral duty to tell your children? And just to give you some background information, symptoms of Huntington's disease usually develop between ages 30 and 50. They can appear as early as 2 or as late as 80, right? So we have a wide swath of time within which this disease usually develops. The hallmark symptom, or presents itself, the hallmark symptom is uncontrolled movement in your arms, legs, head, face, upper body, etc. Huntington's disease is also associated with a decline in thinking and reasoning skills, and this could include concentration, issues with judgment and memory, etc. So with this background, do you have a moral duty to be tested? And if the test is positive, do you have a moral duty to tell your children? And this is something that if you weren't here on Friday, that you should or could definitely discuss with your peers in the discussion forum. Now, genetic testing really, or ethical issues concerning genetic testing, really comes down to respecting a patient's autonomy versus potentially doing no harm. So some bioethicists and medical professionals argue that it's a woman's choice, in this case, the woman's choice, or it's a person's choice, whether or not to disclose information, right? Especially since in the case of Huntington's disease, say that 10 times fast, there's no cure. So you're adding stress. You could argue that you're adding stress to the children. And so the parent has the right, just by an exercise of autonomy, whether or not to disclose information. And as we talked about, information is protected. Privacy is important in medical contexts. Right? But then we have other bioethicists who are arguing on the case of non-maleficence. And they're like, no. We have a duty to do no harm. This is one of the oldest principles in biomedical ethics. Do no harm. So you need to tell the children, because not telling the children will harm the children. They won't be able to take preventative steps. They won't be able to monitor. They could decline and not realize that this is Huntington's disease, etc. This could impact the quality of their medical care, because their medical professionals, their medical doctors, etc., nurses, they do not have the requisite information to provide comprehensive treatment, right? So you can see both, right? Privacy is important. Respecting the choice of the patient is important. It is key. Bedrock principle of biomedical ethics. And yet, not having that information could cause a wide amount of harm, both to the patients who could potentially develop said disease, and also it could impact the quality of care moving forward. So how do we weigh this? Autonomy versus paternalism, autonomy versus non-maleficence, protecting patients' confidentiality versus doing no harm, right? So this is a difficult question. Now, in addition, there could be questions or concerns over genetic discrimination. So many healthcare professionals argue that urge patients to disclose information. However, some patients are reticent to disclose information because employers, insurance companies, and others could use this information to discriminate against the patient. Like, let's say you're carrying a particular disease that could render you unable to fulfill your job in a couple of years, right? Your job duties, etc. Or let's say you're currently paying a relatively low amount in health insurance, and however, if the health insurance companies found out that you have a history of developing a particular ailment, your premiums could go up, and that's the least impact. But you could also lose your health insurance. You could not have insurance moving forward because of this increased probability. And so the question is this a type of genetic discrimination? And should privacy be protected to ensure that patients do not face this type of discrimination? So the main ethical principle at play here is justice, or whether or not people are being treated fairly. Okay. So I want to show you a brief video sort of to set the stage for discussions moving forward.
Some health insurance customers have been offered what seems like a good idea. For just over $500, they can find out whether they have the genes for illnesses such as diabetes and cancer. The insurance company involved says it won't have access to the information, but there are concerns about the legal and financial implications for people who are genetically predisposed to certain diseases. This is the letter that appeared in the mailboxes of 5,000 customers of NIB Health Insurance. It offers half-price genetic testing to assess people's risk of developing diabetes, obesity and some cancers. NIB Chief Mark Fitzgibbon took the test himself.
I had an elevated risk for prostate cancer, and one of the first things I did after receiving that report was go have a check with my local GP.
But privacy experts are concerned. Dr. Chris Barlow-Stewart says finding out you have the genes for a condition can have serious legal implications.
So you just send your DNA out of the country, and you will then get a letter back in the mail or perhaps on the internet saying what your future health is supposedly supposed to be.
Once someone knows they have certain genes, that information must be disclosed when they apply for life insurance. Already in Australia, there have been cases of people facing discrimination once they revealed they had particular genes.
It might come totally out of the blue that you are at risk for a particular condition. And so this is probably going to be as much as a surprise for you as it is for anybody else and the insurer.
NIB says the information is only shared between the genetics company and the patient, not the insurance company.
But I have no doubt in my mind whatsoever that in 10 years' time it will be the standard that your GP will have this information and will rely on this information in helping you make better decisions about your health.
Genetics experts say while knowledge is power, controlling what happens to that information is the key. Sophie Scott, ABC News.
All right, so again, we have privacy coming into question. Is it a matter of privacy here? Should insurance companies know? Should your primary practitioners know what you're predisposed to, what conditions you're predisposed to develop? And is this a question concerning privacy, or is this a question concerning having more information, right? And what do the biomedical principles say here? Because it's quite the hot issue, as so many things are in biomedical ethics and in medicine proper. Right, so with this, I will leave you here, and I am looking forward to the discussion next week, and I will see you hopefully on Friday classes, but just in case, wanted to make sure that you guys were all caught up with the material. So take care and have a great weekend.